Welcome everybody to the lesson where we discuss history taking in diabetes insipidus patients with a specific focus on DDAVP questioning and fluid regimen questioning. So let's start off with DDAVP. I'm going to make a graph here where on the x-axis I'm going to have time in hours of the day, and on the y-axis I'm going to have my sodium levels. And I'm going to draw two dashed lines, one for what the lab considers to be upper limit of normal and what the lab considers to be lower limit of normal. Let's say those are 145 and 135 levels of sodium. So if you have a patient here on the white line, they are going to be hovering anywhere between the normal range, and at some point the last dose of DDAVP they took is going to wear off. So they're going to start having polyuria. Usually that polyuria should last, and we want it to last for an hour or two before giving the next dose. The reason why we want it to last that long is because we want it to lose enough fluid so that the sodium treks up a little bit. And at that point, it's time for them to have their DDAVP dose, which I'm going to mark here in red. Notice that the sodium at that point is above what we consider to be normal, and soon after that, it's going to start trickling back down because the DDAVP is going to make them hold water. They might even hover under the lower limit of normal, and then eventually the DDAVP's activity is going to wear off. They're going to go into a second period of polyuria, and then it's going to be time for their next DDAVP dose. The interval between these two doses can vary and is very patient specific. Some people take DDAVP every 12 hours, others every 24 hours, others every 8 hours, but the key concepts are the same. You want the polyuria before. Let's take an example of a patient that does not have the polyuric phase before the dose. I'm going to mark them here in yellow. So the sodium is going to keep trekking in between normal levels, and it's going to be time for the dose. If they haven't had polyuria and they still give that dose, I'm going to make it here again another red arrow. The DDAVP is still going to work. It's going to make them hold even more fluid so that the sodium doesn't just drop to normal values. Some patients come in the emergency department with a sodium of 120, sometimes 115. So let's focus on sodium now. Since we mentioned it, I'm going to put sodium checks here on light blue, and I'm going to have 3 points. One right before the dose for my two patients, A and A prime, B and B prime, and then C at the lowest level of the sodium for the day, and C prime. So let me zoom out here, make some more space for us to note some things down. Remember, for my patient in yellow, we said that polyuria is very important to be happen right before the dose. We're not talking about polyuria the whole day, but we're talking about polyuria right before the dose, because that's going to protect you from hyponatremia later on when the DDAVP is at full activity. The other thing to notice from the graph above is when you check the sodium makes a big difference depending on what phase of the day they are. So the sodium levels clearly depend on the timing of the last DDAVP dose. And let's set some examples here from our graph above. On the left hand side, I'm going to have what's clinically normal, what makes sense for that patient. And the right hand side, I'm going to write what is abnormal, no matter what the lab says. So you can see point A should be around 150, 155, which should happen right before the dose. We want that. However, if right before the dose you're of sodium of, let's say, 138, that's not going to be good for you for the rest of the day. Point C, which is the lowest point for the patient in white, should be 131, but for the patient that didn't have the polyuric phase, it can be as low as 119. Out of all these values, the lab is going to tell you that the only normal one is the 138. However, that's the abnormal, and it's going to flag as abnormal the 150 and the 131. However, they do make sense for that patient for that day. So let's scroll to the left and make some important questions that we need to ask. The questions that need to be asked for these patients are what dose of DDAVP they're on, find out the regimen, how frequent they're taking it, the route they're on, and keep in mind that there's 3 ways of giving it. You can give it subcutaneously, you can give it in the nose intranasally, or PO, and there's relative strengths of these are such that the PO is 10 times weaker than the intranasal, and that's 10 times weaker than the subcutaneous dose. And then we need to know if especially if they're taking a PO, if they're able to tolerate that dose. But remember, from our blue points for the sodium checks, it's very important to ask when the last dose was given. That's going to be key in determining how severe the dehydration is, how severe the fluid overload is. So let's scroll down now and let's talk about fluid questions in DDAVP. We're going to keep this very simple, and we're going to take an example of two patients. I'm going to have patient A on the left and patient B on the right. They both have diabetes insipidus, but the difference between them is if they have an intact thirst mechanism. We're going to say that patient A has an intact thirst and patient B does not have intact thirst. If you do not have an intact thirst, then you're much more at risk for getting dehydrated or overhydrated. That is because you can't sense that your sodium is rising, and you can't sense that your sodium is getting lower and lower when you're fluid overloaded. So clinically, when you're thinking of the risk of, let's say, hypernatremia for any patients, patient A that has intact thirst will have low risk, but patient B will have a very high risk for that. And the same goes for a risk of hyponatremia, with the patient A not feeling thirsty and not drinking after a while if they have a good fluid status, but patient B can keep on drinking and keep lowering the sodium down to the 1-teens. So the questions that need to be asked specifically for patient B is, how many fluids are you taking a day? And that's usually a calculation that is based on mLs per kg per day, but most of them are going to know that they have to take a specific amount of mLs a day. For both patients, it's very important to know if they have any ongoing fluid losses, because that's going to affect the fluid status. So let's quickly scroll back up and review the key concepts we talked about. Specifically the DDAVP, we said that polyuria right before the dose is the thing that's going to protect you against hyponatremia. And the sodium that you're going to get, you have to see in the context of when was the last DDAVP dose given. Because even if you get what the lab says is abnormal values, they might be absolutely normal for the clinical situation. The questions that we need answered for the DDAVP is the dose, the route, and if they tolerated the DDAVP, and very importantly, when was the last dose given. Let me scroll down here and talk about fluids. We said that for the dangerous patient is a patient that does not have an intact thirst mechanism. That's going to happen because they are at risk of hypernatremia, they're at risk of hyponatremia, and they should have a specific prescription of mLs a day that we need to know. For both patients, either they have an intact thirst or not intact thirst, it's absolutely vital to know if they have any ongoing fluid losses. Thank you so much for listening. Make sure that you check out the other endocrine videos online.